Hello everyone, welcome. Today we are discussing about approach to hemolytic anemia. Hemolytic anemia is defined by premature destruction of RBC. It can be intravascular or extravascular. When you suspect a patient for hemolytic anemia, then check for the clinical concerns of hemolysis like jaundice, anemia and fatigue. Go for initial hemolysis workup includes reticulocyte, lactate dehydrogenase, haptoglobin, unconjugated bilirubin, urine analysis. The features of the hemolysis are increased reticulocyte count, increased LDH, decreased haptoglobin, increased unconjugated bilirubin, urobilinogen and blood in the urine. Initial workup shows the features of hemolysis, then look for the peripheral smear. Look carefully for RBC morphology. Is there any cystocyte, sickle cell, bite cell, elliptocyte or spherocytes are seen or not? Let's say you are observing the cystocyte on the peripheral smear. What are cystocytes? Cystocytes are fragmented RBCs reserved from the intravascular destruction. Criteria for significant cystocytosis is presence of more than or equal to 1% cystocyte in the peripheral blood smear. Take a history for any trauma like March hemoglobinuria, recent bypass surgery, AV malformation, mechanical valve. If any of the history is present, and treat accordingly. If history is negative for trauma, then see for the rash, infection or travel history. If the answer is yes, then consider rickettsia, malaria or HIV. Advise diagnostic test for these infections. If answer is no, then consider the MAHA and thrombotic microangiopathy. MAHA means microangiopathic hemolytic anemia. It is a descriptive terminology for hemolytic anemia that occurs when RBC fragments and result in the cystocyte formation. They are visible on the peripheral smear. This is caused by the trauma from endovascular device or the microthrombi. It mainly includes TTP, HUS and others. TTP is thrombotic thrombocytopenic purpura. It is characterized by significantly reduced ADA-MTS13 enzyme activity. The function of ADA-MTS13 enzyme is to cleave the von Willebrand factor aggregation. When it is not present or reduced, the large von Willebrand factor multimer forms. And this multimer traps the platelet, forms the microthrombi and RBC destruction by shearing. The classical pentrad of TTP is thrombocytopenia, fever, kidney injury, microangiopathic hemolytic anemia and neurological dysfunction. In additional testing, DAT is negative and coagulation profile is normal. The assessment of ADA-MTS13 enzyme activity is diagnostic of TTP, but it can take time for result to come out. So the plasmic score is used for the prediction of severely reduced ADA-MTS13 enzyme activity. What is plasmic score? It includes the 7 criteria and 1 point for each criteria. The criteria includes platelet count less than 30,000 per microliter, hemolysis, no cancer history, no transplantation history, MCV less than 90 femtoliter, creatine less than 2 mg per dl and INR less than 1.5. If the score is 0 to 4, then it suggests low risk. If the score is 5 to 6, it suggests intermediate risk. And if the score is 7, then it suggests the high risk. If the score is more than equal to 5, then we can consider low ADA-MTS13 enzyme activity and we can start treatment for TTP. The next is hemolytic uremic syndrome. The classical triad of HUS is microangiopathic hemolytic anemia, acute kidney injury, and neurological dysfunction. 90% of HUS cases are due to the infection of Shiga toxin producing E. coli, also known as STEC HUS or typical HUS. It predominantly affects the children. Symptoms are abdominal pain with diarrhea preceding the MAHA, kidney injury, and thrombocytopenia by 5 to 10 days. Other infections are STEC UTI by diarrhea negative STEC HUS. Strep pneumonia, HIV, influenza may be associated with HUS. Atypical HUS occurs due to hereditary condition and not by the infection. Source of the infection is inadequately cooked ground beef, fruit, vegetable, poultry, and contaminated water. The Shiga toxin is absorbed and attached to specific receptor most expressed in the glomerulus, kidney, and the brain. Causing endothelial damage leads to the formation of large von Willebrand factor multimers, which induce the microangiopathic hemolytic anemia. The treatment is supportive care and continued evaluation of renal function test. Antibiotics are generally not recommended. Other microangiopathic hemolytic anemia syndromes include HELP and DIC. HELP is hemolysis, elevated liver enzymes, and low platelet count. It occurs in the pregnancy. LDH to AST ratio is low. Hepatic involvement is high. The DIC is disseminated intravascular coagulation. It is an emergency. It causes prolonged coagulation studies, positive D-dimer test, and decreased fibrinogen level. It results in microangiopathic hemolytic anemia due to fibrin-rich microthrombin formation. The next we are seeing is drug-induced thrombotic microangiopathy. The drug causes formation of platelet microthrombi by induced antibodies or direct toxicity of the drug. Examples of the drugs are bupropion, chemotherapy, clopidogrel, cocaine, ecstasy known as 3,4-methyl NAdeoxymethamphetamine, cyclosporin, ibuprofen, interferon, mefloquine, metronidazole, nitrofurantoin, quinine, tacrolimus, trimethoprim, and sulfamethoxazole. Let's see on peripheral smear we find the sickle cells. Sickle cell disease is a group of hemoglobinopathies that includes the mutation in the gene coding the beta subunit of hemoglobin. This group includes sickle cell anemia, hemoglobin S, C disease, hemoglobin sickle beta thalassemia, and sickle cell trait, hemoglobin AS. Sickle cell anemia is the most common form of sickle cell disease with a lifelong affliction of hemolytic anemia requiring blood transfusion, pain crisis, and organ damage. Two major components is hemolysis and vaso-occlusive crisis. A defect in the beta globin gene leads to formation of the rigid elongated polymer. In deoxygenated state, it is known as sickle cell, which leads to hemolysis. And in oxidative stress leads to cell membrane damage, that is also leads to hemolysis. The diagnosis of sickle cell disease is done by HB electrophoresis and by molecular testing. If you find bite cells and the Hens bodies in the peripheral smear, it may suggest G6PD deficiency. Oxidative hemolysis occurs when the normal processes are unable to reduce ferric 3 plus ion, also known as methemoglobin, to ferrous 2 plus ion, which carries the oxygen. This results in methemoglobinemia. Denaturing of ferric hemoglobin into multimer, this is called the Hens bodies. This leads to premature destruction of RBC by phagocytosis. G6PD is integral to this protective system. G6PD deficiency is an X-linked disorder. Favabin, sulfa drugs, and primaquine are the primary triggers for oxidative hemolysis. The diagnosis is made by the G6PD activity testing, though it may be normal during or just after the hemolytic episode. Some drugs like amyl and butyl nitrate, topical benzocaine, dapsone, ribavirin, and paraquat injection leads to oxidative hemolysis even with the normal G6PD. The treatment is discontinuation of drug and supportive care. If you find elliptocytes on the smear, it may suggest hereditary elliptocytosis. In peripheral blood smear, almost 15% to 100% of the RBCs are elliptocyte in the hereditary elliptocytosis. It is inherited heterogeneous RBC disorder characterized by the elongated oval or elliptical shaped RBC on the peripheral blood smear. Extravascular hemolysis occurs. Genetic alteration affecting the cytoskeletal protein present in the RBC membrane result in the RBC membrane stability defect as they passes through the microcirculation. This RBC fail to remain normal biconcave shape as they pass through microcirculation. These elliptocytes are trapped and removed by the spleen, resulting in the premature destruction of RBC. Asymptomatic individuals without hemolysis do not require treatment. Individuals with intermittent hemolysis or anemia may require blood transfusion. Splenectomy is reserved for patients with a severe anemia that is life-threatening or require regular blood transfusion. If you find a spherocyte on the peripheral blood smear, then one should go for the DAT testing. DAT is a direct antiglobulin testing. If DAT is positive, it can be due to drug-induced immune hemolytic anemia or due to the autoimmune hemolytic anemia. Drug-induced immune hemolytic anemia is rare. Drugs involved are methyldropa, penicillin, cefotetan, cefotrexan, piperacillin, and NSAIDs. Treatment is removal and discontinuation of the drug. AIHA, autoimmune hemolytic anemia. It is caused by the increased RBC destruction triggered by autoantibodies reacting against the RBC antigen with or without complement activation. Two primary subgroups based on the binding temperature referred as a cold and warm agglutinins. The causes are idiopathic, however, viral and bacterial infection, autoimmune condition, connective tissue disorders, lymphoproliferative malignancy, blood transfusion, and transplantation are associated with autoimmune hemolytic anemia. The warm autoimmune hemolytic anemia are more common than the cold AIHA. It involves IgG and autoantibodies. On the peripheral smears, spherocytes are seen. These IgG coated RBCs are removed by the reticuloendothelial macrophages and sequestered in the spleen. The treatment is glucocorticoid and the management of underlying condition. Cold autoimmune hemolytic anemia involves IgM antibodies on the peripheral blood smear, the RBC agglutination seen. IgM antibody react with RBC antigen on the RBC surface at the low temperature and cause lysis on the rewarming by the complement fixation and intravascular hemolysis. It is associated with infection or malignant process. The treatment involves supportive measures and underlying disease management. Direct antiglobulin test is negative and spherocyte is seen on the peripheral smear. Then evaluate with eosin 5, maleimide test and osmotic fragility. If decreased dye binding in the EMA test and increased osmotic fragility is observed, then it is suggesting hereditary spherocytosis. It is an autosomal dominant inheritance disorder. The treatment is symptomatic. Blood transfusion is required for severe anemia and splenectomy is suggested for the severe cases. This is the reference for this video. Thank you.